Hello and welcome to the Check Rare podcast. My name is Peter Suzuki and the topic of today's discussion is Fabry disease, a rare inherited lysosomal disorder that affects many organs, including the heart, kidney, and nervous system. It is a progressive, lifelong condition. This is the first part of our series focusing on Fabry disease. Today, we'll be talking to Dr. William Burns, who will provide an overview of this rare disease, including current management strategies. Dr. Burns is a biochemical geneticist at Greenwood Genetic Center in Greenwood, South Carolina. Hello, Dr. Burns. Thank you for your time today. Can you introduce yourself and tell us about your work?
Well, hi there. My name is William Burns. I'm a biochemical geneticist at Greenwood Genetic Center, and I work with our lysosomal storage disease program treating patients with Fabry and other lysosomal storage diseases. My experience mainly came when I was in residency, or at least my initial experience with Fabry disease as a genetics resident at Greenwood Genetic Center, working with the team down there who followed a number of Fabry patients across the state of South Carolina.
What is Fabry disease?
Fabry disease is a rare genetic condition caused by pathogenic disease-causing variants in a gene called GLA. That gene encodes an enzyme called alpha-galactosidase that is involved in how we break down certain metabolites in the lysosome, which is kind of a part of the cell that acts as a recycling bin. And the disease, because of that difficulty, leads to storage of these kind of parts that don't get broken down and gets categorized as what's called a lysosomal storage disease. So there's a number of organ systems that get affected, and that is what ends up causing so many specialists to be involved. I think the ones we think of the most often are probably the kidney and the heart, but we also see issues in the brain and nervous system, the skin, and the eyes. And then more recently, there have been some studies showing some major issues with hearing or the audiologic system.
How do patients typically present?
And it really depends on type of Fabry disease and also if they're male or female. So I would say it's males, at least with the classic type, tend to present in childhood or adolescence, most frequently with things like reduced sweating, pains in their extremities, and things called angiokeratomas, which are small reddish skin markings that we see. Sometimes, depending on how early or how late they've been caught, you may already start to see some of the kidney issues with proteinuria and GI issues like chronic abdominal pain. With females, it's a lot more difficult because it's an X-linked disorder and because there's variation in which organs express which gene. You tend to see anywhere from asymptomatic throughout their entire life to more frequently at least having some milder symptoms presenting later in life. And I would say more commonly what you're seeing with them is the chronic abdominal pain, something called corneal verticillata, which is an eye finding, and in some cases, the kidney issues and heart issues, depending on how late you've caught them. There was a study in 2004 that I think looked at the path to diagnosis from the time of symptom onset. It was on average 10 to 15 years, and I don't think that's changed much even in the last decade or so.
What is the typical diagnostic journey? What specialty is likely to pick up on a patient having Fabry disease?
So again, it can vary depending on what symptoms are going to show up. I would say in females, I think the most often specialty we get referrals from is ophthalmology because they might be getting seen for some vision issues and the corneal verticillata will get noticed. For a more classic male, we've had referrals from nephrologist. I would say dermatology is quite common where they've caught the angiokeratomas and have kind of gotten diagnosed and sent to us for that direction. And sometimes neurology, depending on if they're having significant nerve pain in their extremities.
How do you identify patients with Fabry disease?
Typically by the time they get to me, someone's probably already at least thought of it. So oftentimes we're using molecular studies or enzyme analysis if we feel like once we've seen them, they have symptoms that are consistent with the disorder. I think that may change over time as we're starting to see newborn screening show up in some of these states where Fabry is going to be caught in infants who are clearly going to not have symptoms yet, in which case we'll be seeing them much earlier, but the diagnosis will pretty much be the same with enzyme analysis and molecular analysis.
How does disease presentation differ within various subpopulations?
Males, especially males with more classic variants, tend to present in that childhood and adolescent period. So we're seeing symptoms earlier. There are more atypical forms that may present with more cardiac issues later in life, in which case it can be several decades, even for the males, although that's less common. And again, females, I've seen presentations anywhere from the teens up into the 50s or 60s before they have really been caught with symptoms. So it varies quite a bit. And it's even that's with both classic and atypical later onset forms.
What are some of the challenges in diagnosis?
That would be most states in the United States are not yet doing newborn screening. And even with newborn screening, you're probably going to miss some females since most of the screening will be done with enzyme analysis. But I'd say the biggest issue and the biggest or the best way to start shortening some of that diagnostic odyssey that they go through is probably just increasing the awareness of Fabry, since it is a rare disease. Most people who are going to see them first before they ever get to genetics, who need to be the people suspecting it and sending those referrals, probably are not thinking about Fabry as much as we do here in genetics. And so just having it on the differential and having a good understanding of what some of those symptoms are for people who, primary care or nephrology, ophthalmology, increasing that awareness would be the best way to do that. I think some of the best ways is just, having a relationship with some of those specialties outside between us and, between genetics or other specialties who have experience with Fabry, and just trying to raise awareness, with our own relationships with other providers in the area. But any sort of, educational programs that can be targeted at conferences that they may go to, or even just community educational programs, ways to get providers involved and to think more about this disorder, especially with the variable presentation, would, I think, help immensely in reducing that diagnostic odyssey.
At what point do you typically see a patient in your care cycle?
So I think with the males, it's again typically probably more in adolescence. Even if they've had onset in childhood, we're not going to see them because it takes so long typically for it to be recognized, usually within 5 to 10 years. By that time, they're probably having fairly significant symptoms. So I usually think they're probably on the more moderate to severe side. With females, again, because their presentations vary so much, at least for initial diagnoses, it's usually pretty late. They usually have a significant issue in at least one of the organ systems, which is how they kind of got diagnosed in the first place. And the other way is that if someone else in the family got diagnosed with Fabry, we typically find several other members who are affected, and we will see people who may not have symptoms yet at that point. It really cannot be understated how long many of our female patients have gone with symptoms that got, unrecognized. I would say most frequently I'm seeing people in their 30s and 40s, and typically they have fairly significant symptoms at that point. And I think because some of these symptoms are not the most common things that we think of with Fabry, since females typically are not as likely to have, say, the angiokeratomas that are more easily recognized. They may not have as much of the pain crises that we typically see in males and think of, that they often kind of fly under the radar. And a lot of the symptoms, if you think about it with Fabry, a lot of the other symptoms are things that you may naturally see as people get older, like chronic abdominal pain, or there may be other causes that providers will want to rule out first. Hearing loss, sweating is not something a lot of people talk about. So whether they sweat or not may not even come up in most conversations. And so I think what happens is people oftentimes, as doctors, we look for the most common cause of whatever symptom we're seeing, and we work those up first. And Fabry is usually much further down the list than most of the other common causes of some of these symptoms. And so females just kind of progressively take longer to work up because their symptoms are both milder and later onset than we typically see with males.
Once a patient is identified, what is your typical treatment paradigm?
Again, it does vary a little bit, but I mean, typically we're going to go ahead and start talking about treatment for most, if not all, patients. And for at least right now, the two options are really what's called enzyme replacement therapy, where they get some sort of synthetic version of the enzyme that they're not currently making to help reduce the storage of these metabolites that are causing the problems, or what's called a chaperone therapy to help kind of stabilize their enzyme to help increase how much metabolite it's breaking down. Rather than breaking it down for them. And typically, especially with classic males, males who are presenting early, we're going to recommend very strongly they start treatment immediately with either one of these. So the chaperone therapy is really only available to certain populations. So they have to have a certain set of variants that have been shown to respond to it, whereas enzyme replacement therapy is typically available for anybody. For females, it can depend on how early they've been caught, and there's a lot of discussion, especially if they're going to need enzyme replacement therapy, about when they want to start therapy. Although we typically would recommend starting it as soon as possible to reduce symptoms. There's a lot of lifestyle change that comes with starting an enzyme replacement therapy. It's biweekly infusions right now for the rest of your life, which can be quite challenging for some families. And it can be also quite challenging depending on what area of the country you're in and what kind of availability you have for infusion centers and things like that. So really, though, we are trying to recommend treatment early with one of those two options, and try to find the best option for each patient.
And can you talk a little bit about your approach, the differences between male and female once treatments start?
Well, once treatment starts, typically we recommend, continuing the biweekly infusions again, at least right now, for lifetime. Now, sometimes we miss some infusions and we push them back, and there's some flexibility there. But once started on treatment, we strongly recommend never going off treatment, because the moment you do, you're going to start losing all that kind of gained time, as the metabolites will just build up. That what's called GL3 builds back up in the cells and will lead to symptoms again. The harder part is just getting people to buy into the treatment, especially if they're on the milder end, and making them understand the importance of starting the treatment early.
How does your treatment approach differ when treating non-symptomatic patients?
I think there's more discussion and more explanation of why we recommend starting the treatments and helping patients understand, even though they don't have symptoms now, those symptoms are expected to show up, and that starting treatment early should hopefully push those symptoms off and possibly give them a much longer time with either without symptoms or with milder symptoms in the future. It can be a very difficult discussion. It's hard to want to make such a significant change when you're feeling fairly healthy, but I do think that, at least in genetics, we're going to have to become much more comfortable having those discussions, especially as we kind of mentioned before, newborn screening coming on. All of those infants will be asymptomatic, and deciding when to start treatment will be a big part of what we do in the future.
What patient archetypes do you think are needing immediate treatment versus maybe waiting on treatment?
So any male with classic Fabry disease should start treatment as soon as possible, in my opinion. Ideally, I would like everyone to start treatment, but I know that especially for females who are asymptomatic, we can't always predict when their symptoms will show up. And so we will usually have a discussion, if they are not wanting to start treatment, if they're very much against treatment for some reason or another, then we will monitor them, and once symptoms start to appear, start treatment immediately. I still recommend starting it, sooner and before symptoms is better, in my opinion. But it is still a discussion with the patient, and so making sure that they're comfortable with whatever decisions are made, so that they get the treatment that they want and get what they want out of our meetings is important. So I think you have a little more leeway in waiting, especially if a female patient does not have recognizable symptoms, and maybe they were identified, secondary to a family member who got diagnosed. But we still strongly encourage it in order to kind of hopefully push symptoms off and give them a longer time frame without those major medical issues.
When children are identified through family screening, what would your approach be for these patients, pediatric patients?
Again, for males, it's an easy question, because if they've been identified separately or through family screening, and we recognize that it's a classic variant, we're going to strongly recommend they start treatment, even if they are pre-symptomatic at that point. For females, I think it again will kind of depend on the age. It'll also depend on if they have other medical issues, if they have other complicating issues that could make it harder to recognize when symptoms are starting. I've had adolescents who had other kidney issues, so then what appeared to be unrelated to Fabry disease, which could have made it harder for us to recognize when symptoms started. In that case, typically we still would recommend starting treatment sooner rather than later. If they're pre-symptomatic and if the variant appears to be either milder or a later onset, we may discuss, waiting and giving them some more time, away from treatment, with the family's knowledge that the longer without treatment, the more likely they will present with symptoms sooner.
How does patient preference factor into your decision making regarding treatments?
It's very important that the patients understand why they're getting treated and that they understand the importance of that treatment and kind of buy in to make sure that both they're getting the treatment as regularly as possible, and that we maximize their ability to, or their desire to get that treatment done regularly. But their preference in kind of what treatment they get, which enzyme replacement therapy they choose, or if they want to start the chaperone therapy, we usually let them decide unless there's some medical reason for us to say that one treatment would not work over another. When choosing treatments, we really try to leave it up to the patient so that they pick whatever's best for their lifestyle.
What factors would drive these preferences?
Well, I mean, chaperone therapy, only a certain subpopulation is even going to get that option, unfortunately. So that is an oral medication. So some patients really prefer that from, you're not getting infusions every couple weeks, and it's a little easier to manage and juggle that rather than these infusion therapies. When it comes to ERTs, or the enzyme replacement therapies, really it's just a preference. There are two on the market right now, and there are some differences between them, and we try to present these in a balanced light as much as possible so that the patients understand what the differences can be both in the future and what may be available now. But really, we just let them pick one. There's not usually, between the two, there's usually not much of a reason to choose one over the other that I have come across. I will say sometimes, insurance may play a role. So if insurance, for whatever reason, has a preference, which is not typical, they usually let the providers and the families decide. But really, it just comes down to whatever the patient's most comfortable with.
What recommendations or guidelines do you follow?
There's several guidelines, both for adults, and there are some for pediatric patients with Fabry. And typically, I review all of those periodically, and also any revisions that come by. And I think they're pretty widely used by most anybody in the industry. I think we all typically review those regularly to make sure that we are up to date on what we're doing. And then also sometimes, between revisions of those guidelines, looking through any literature that may give us additional information or updates that may change how we practice can occur. Again, maybe finding out that, hearing loss was more common than we realized initially, and that, or something similar may change or have us add to our treatments, that even between guideline revisions, since the guidelines are usually only updated every 5 to 10 years right now.
What are the goals of treatment?
So we do follow a couple of things laboratory wise, and also some imaging findings. So we follow kidney function and kind of look at protein in the urine. We like to make sure that that stays within normal range, or if the patient already had that at the time of diagnosis, that we're not seeing it increase over time. We expect that even with treatment, these treatments aren't perfect, so they don't stop disease progression. They aren't a cure, but what they do is slow down that progression. So what we want to see is that their decline is, extremely, hopefully slow. And if we start to see that increase, we have to look into other reasons for what may be leading to that. But the other things is really just patient response. So some of these things are things that patients are experiencing, and we can't necessarily, measure their pain scale all the time, or how often they're having pain crises, or if their chronic abdominal pain or GI issues improve. We want to hear the patients tell us that they're seeing improvement. And one of the important labs we check is something called a GL3, which is that compound that builds up over time because that enzyme is not working appropriately. We want to see that go down. We expect that it'll start to go up again over time, but at least, especially after treatment has started, we want to see that level decrease and hopefully stay low. Although it's not a perfect indicator of how well the drug is working all the time.
What is the best case scenario for patients?
I would say best case scenario for all of our patients would be pre-symptomatically being diagnosed and starting on treatment immediately. Starting on treatment has been shown to push off symptom onset if you're started prior to symptoms beginning, and to give you an increased kind of lifespan, and I would hope an increased quality of life if we're pushing off those symptoms starting. I think that's most ideal, especially in kind of the classic cases, both for male and female, but even for kind of the more atypical later onset forms of Fabry, catching it early and starting treatment is the ideal and kind of the goal for all of us.
What does personalized medicine mean to you?
When I think of personalized medicine, I think of specific targeted treatments for each person based on whatever variant or genetic defect they have, or genetic disorder, I think would be preferable. And treating that either specific down to whatever, misspelling is in that gene or whatever enzyme, amino acid is missing, or even just, again, if we're replacing a whole gene with something like gene therapy, giving them a working copy of that gene to replace it.
What are the goals of personalized medicine in Fabry disease?
So it somewhat depends on, I guess, what you think of as personalized medicine. So personalized medicine and genetics, especially, is, our goal would be to treat each individual based on what variants they have and what specific issues are in the enzyme. I think right now it's mostly just treating specifically for Fabry disease. Enzyme replacement therapy provides you that extra synthetic enzyme that replaces the function of the one you're missing. I think the goal eventually would be what's called gene therapy, where we focus and give people, a new copy or a working copy of that Fabry gene so that they can produce their own enzyme. That would be about as personal as you can get, I think.
What do the current therapies do for Fabry disease patients? How effective are they?
So in general, it's important for people to know, even before they start treatment, we try to always make sure our patients understand that these treatments are not perfect. So none of these treatments cure the disease. They don't stop Fabry progression. What they do is slow the progression of the disease. So each of the different therapies, the goal is to reduce the storage of that metabolite, that GL3 that we talk about, and that is what they do. And again, because it's a storage disease, the symptoms show up as you build up that metabolite. So what the enzyme replacement and the chaperone therapy both do is help your body help your enzyme get rid of it more quickly with the chaperone therapies, or provide you an extra enzyme to rid your body of that storage. But over time, that storage is going to continue. So the earlier you start treatment, the less storage you have, the easier it is to clear that storage before symptoms start. And so really the treatments, again, started early. The goal is to kind of push back symptom onset. Once symptom onset starts, that hopefully if you continue treatment, the symptoms will be slower in their progression than they would have been if you were not on treatment. If you're already symptomatic, what we hope to see is that you have some improvement in your symptoms when you start therapy, and that we slow progression of those symptoms as time goes on. Again, all of that depends on the patient, again, continuing treatment regularly and making sure we're not missing treatments or having reactions. But those are kind of the major goals. And I think, from a clinician standpoint and from the patient standpoint, the goal one day will be to have a treatment that actually cures the disease. But unfortunately, that's not the case for either of our treatments right now.
It's great that there are treatment options for this rare disease, but what would you like to see for this community in the future?
I think what we kind of all really want to see is a curative therapy. So, and I think gene therapy is probably the one people most likely are talking about right now, because we're seeing a lot of action, movement and changes in that field. And if we do have a therapy like that we catch individuals early, so newborn screening is a big part of that, and that we treat them as soon as we can, so that hopefully they never see symptoms. And again, we also want that therapy to be something that most people can tolerate and do well with, rather than it be, something in which most patients are having, serious adverse reactions. So I think a safe curative treatment is what we all would like to see, and one that we can start early.
Thank you, Dr. Burns, for your excellent insight into Fabry disease and for explaining this rare disorder, as well as current and emerging management strategies. This concludes our first part in our series on Fabry disease.